Hi, my name is Jason Bartlett, an ACP with the Queensland Ambulance Service in Brisbane. Today I'm going to do an exemplar video 1 for PAR 5440. For myself, that is going to be external jugular intravenous cannulation. The presentation will be based on a few different parts. First, I'll talk about the indications, contraindications and some complications of EJ cannulation. Then I'll talk about a few tips and techniques about patient presentation, patient positioning, preparation, etc. The respiratory pump and the effect that has during EJ cannulation, and then I'll run through aseptic technique preparation and a practical demonstration of the actual skill of EJ cannulation.
According to the Queensland Ambulance Service Clinical Practice Manual, the indications for external jugular intravenous cannulation include the emergent IV access for the administration of medications and/or fluid when other peripheral IV access is unavailable. It's contraindicated in agitated and uncooperative patients, or where burns, infection or localized cellulitis complicate the access site. Complications can include drug or fluid extravasation, hematoma or hemorrhage from the site of cannulation, infection or phlebitis, introduction of a venous air embolus, and arterial puncture, which is quite significant in EJ cannulation given the proximity to the carotid arteries underlying the sternocleidomastoid muscle.
Okay, so I'll give a practical demonstration of the actual procedure of external jugular venous cannulation. Brian, my colleague from work here, is going to be my model. I won't actually cannulate because it's beyond my skill set at this stage, but I'll simulate the cannulation. In preparation for an EJ cannulation, positioning of the patient is very important. First of all, making sure we've got our safety equipment on, goggles, gloves. It's a high risk body fluid contamination procedure, so we want to make sure that we've protected ourselves. So the external jugular vein runs superior to the sternocleidomastoid muscle, which runs from the angle of the mandible to the clavicle. Sits on the outside of that. Some people actually have dual EJ veins. In this case, Brian's only got a single EJ. Ideal patient positioning, we can put a patient in what they call the Trendelenburg position. So we want to increase venous filling to facilitate us getting a good cannula. So by doing that, we can either choose to drop the patient's head 15 degrees, maintaining a good position so he's still in a safe position for me to cannulate, he's at the right height. Alternatively, in a situation where, say, the patient's on the stretcher in the back of the ambulance or they're on the ground and we can't actually drop their head 15 degrees, what we can do is put the patient into what we refer to as the modified Trendelenburg position, where we lift the patient's legs to facilitate some postural drainage. In this case, because Brian's on a stretcher and we can put him in the proper Trendelenburg position, I'm going to drop the head of the stretcher a touch, just to facilitate some venous filling. Obviously we can't tourniquet this vein because we don't want to cut off cerebral blood flow for a start. So if we rotate the patient's neck between 45 and 60 degrees to the side, obviously if there's C-spine precautions, this is not an option. It's contraindicated in C-spine precautions because we don't want to tilt the neck. You still can cannulate the EJ vein with C-spine precautions, that we just don't rotate the head. Obviously with the availability and of IO kits and how readily available they are and accessible, and how people are now trained in IO, in someone who has a C-spine precaution would obviously be going for an IO if it was possible. So we can see that in this case Brian's EJ vein runs basically from the angle of his mandible to the medial aspect of his clavicle. Now if Brian takes a breath in, we'll notice that because of the respiratory pump and his respiratory drive, as the intrathoracic pressure reduces, he gets venous drainage into his thoracic cavity, into his heart and into his circulatory system again. So obviously we don't want that to happen. So one way that we can control for that respiratory pump is to actually occlude the vein above the clavicle with one hand, and we can see that we can then get engorgement of the EJ vein. So as with any IV access or any peripheral venous access, we want to maintain sterility. We're compromising the patient's integumentary system, which is the majority of their external immune system. So we want to make sure that we're well and truly sterile using aseptic technique. In this case, we'll choose to swab twice. So I've got all my gear laid out on a clean aseptic area. I've got my 18 gauge cannula, I've got a sterile bung, got a pre-flushed and pre-readied IV line. I've got a saline flush drawn up, and I've also got a second cannula that I can use to aspirate some blood if we were going to take some blood off this cannula. And I've got my my op site to secure it. So as I explained before, we want aseptic technique, so we'll swab the EJ vein. I'm going to use my finger to occlude it at the area of the clavicle. It's my 18 gauge cannula. I would come in at a 15-degree angle, approximately halfway between the angle of the mandible and the clavicle. It's a dangerous cannulation position because your finger is actually in front of the line of the cannula, which is not a normal procedure. So we be extremely careful of needle stick injuries. Once we've got tamponaded the vein, at 15 degrees we'd puncture into the EJ vein. I won't do it because it's beyond my skill set, and once the cannula is actually engorged, we'd look for flashback into the cannula, occlude the EJ vein, put on a bung, and with some saline flush, confirm placement by positive saline flush. Or we could aspirate blood off at the same time to ensure that we've got a patent cannula. Once we've ensured patency with my op site, we'd secure the EJ cannula in situ. Ensuring that we've got no extravasation, no hematomas outside the cannula. And then I would attach my pre-flushed fluid line. It's a bit easier to access. So sharps into the sharps container. And then we could flush our cannula just to ensure patency, which we have a patent cannula.